Hi, this is Stephen, and in this video we will discuss some non-ischemic processes that can lead to wall motion abnormalities that you should be aware of. And so this is your normal left ventricle, the parasternal short axis view with the right ventricle up on the side. What if you see something like this? You see that instead it looks like a D with a large right ventricle. Well, in this case, let's shade in our LV. This can correspond to one of two different things. If the septum is shaped like a D both in systole and diastole, this would be right ventricular pressure overload. And if it is only present in diastole, remember in diastole the pressures are much lower in both the left ventricle and in the right ventricle. So if this D septum is present only in diastole, we'll say if only in diastole, then this would be RV volume overload, excessive volume. Okay, so if the pressure in the RV is much too high, then both during systole and diastole, it pushes against the left ventricle, and the left ventricle, you can just basically imagine that if there's too much volume, then during diastole, the septum will flatten, but during systole, when the left ventricle is muscular and pumping, it will resume its round shape. However, with significant pressure overload, then even during systole, the left ventricle will be deformed by the right ventricle. Now, one other one to be aware of is you may see something like this. You may see that in more of the inferior distribution, there's flattening, and this is typically worse in diastole. As we mentioned before, diastole is when the pressure is lower in the left ventricle, so it's easy to deform. And what could cause this? Well, again, I want you to think about what could be pressing up from here, and any kind of abdominal disease process where there's increased pressure. You can see it in pregnancy if someone has significant ascites or something else where there's a buildup in abdominal pressure. That can cause this inferior wall deformation of the left ventricle that you might be initially confused for ischemia. But again, it'll typically be more pronounced in diastole when pressures are lower. A few other things to be aware of. If you have constrictive pericarditis, or just constriction in general, let's keep it a little more broad. If you have constriction, that means that wherever the heart muscle is constricted, typically with the pericardium, those walls will not move as well, whereas the septum may move nicely. And also if you have a left bundle branch block, or if you have pacing, that will alter the pathway of depolarization and also then lead to ventricular movement, particularly in the septum, that looks a little different, that is not due to ischemia. So just a couple other things to be aware of that can cause different changes in how the walls move that are not due to ischemia.